The reason why ketamine is such an interesting medicine in the psychological context is because it doesn't just dissociate us from physical pain. It dissociates us from emotional pain, which Tor Wager and a number of other folks showed at some really fascinating studies 10, 15 years ago are actually relatively indistinguishable in the brain via neuroimaging. Emotional and physical pain kind of look the same.
All right. Welcome back to the Smarter Not Harder podcast, your home to life's one-cent solutions to $64,000 questions. Before we get started, don't forget to hit the like or subscribe button, depending on how you're listening to this, so you never miss an episode. Every week, with a rotating group of awesome hosts, including yours truly, we interview top experts in health, movement, psychedelics, fun pharma, enlightenment, performance, and much more. Today, my guest on the Smarter Not Harder podcast is Dr. Dave Rabin, and Dr. Dave's a good friend. He is a clinical neuroscientist. He is a MD, board-certified psychiatrist. He's a health tech entrepreneur. He invented the Apollo, and his company, Apollo Neuroscience, is creating wearable technology using touch and simulating touch and doing some amazing things. He also is the co-founder and executive director of the Board of Medicine, a 501c3 nonprofit organization of physicians and scientists establishing the first peer-reviewed evidence-based clinical guidelines for the production and safe use of currently unregulated alternative medicines, including plant medicine. The Board of Medicine is training and certifying healthcare providers and providing quality control standards for complementary and alternative medicines to support high-quality clinical research, best practices, and risk reduction. I'm very excited about his endeavor there. Dr. Dave is also conducting research on epigenetic regulation of trauma responses and recovery to elucidate the mechanism of psychedelic-assisted psychotherapy and the neurobiology of belief. He is MD and Ph.D. at the Albany Medical College and specialized in psychiatry with a distinction in research at the Western Psychiatric Institute and clinical at the University of Pittsburgh Medical Center. His co-founder, Catherine, he and Catherine have been married since 2016. And I met Dave in 2019, as we'll talk about in this podcast. We had a great time talking about a lot of different topics. We dove into psychedelics and neuroplasticity. We spoke about ketamine in detail, as well as mechanisms of action that we understand and the ones that we don't. We also spoke about the parasympathetic and sympathetic nervous system and the balance in creating a safe space for patients when they are going through psychedelic-assisted psychotherapy or mental health treatment in general, and how Dave approaches that with his patients. We talked about nutrition. We talked about movement. We talked about talk therapy. We talked about psychedelics and the ketamine experience itself. We also touched upon touch itself with his Apollo and how Apollo allows people to create a safe space, even if they're not in clinic with Dave and his other clinicians doing ketamine-assisted psychotherapy, which they're doing in people's homes. We also spoke about his overall approach to patients when they come into his clinic and how that works, creating that safe space before, during, and after a psychedelic-assisted journey with ketamine at this point, given it's the legal psychedelic that we have. We also spoke about his nonprofit organization, his recent W.H.O adventures, and speaking to developing countries about psychedelics and ketamine as well. And we ended up finishing up the conversation talking about when psychedelics go wrong and some of the ways that he works with clients. And he says, actually, they're some of his favorite clients that he works with in how he can help them recover from what we call psychedelic-assisted psychosis, interestingly enough. So I thought this was a great episode. We had a lot of fun. I hope you guys enjoy it too. Please remember to like and subscribe, and wishing you a most fantastic rest of your day. Dr. Dave, how are you?
Great. It's good to be here with you, Scott. We've been planning to do this for a long time. So
yeah, it's been a long time getting to know you, since 2019 when I first met you in the UK, and you were running around strapping things onto people's legs and excited about what was to come in the last several years. Has been like crazy for you and your team, and I'm really excited for you and for Catherine and for the whole Apollo team, what you guys have been able to do. But I think where you and I really resonated and connected is on the clinician side, being clinicians ourselves, you being a psychiatrist and neuroscientist, me being an internal medicine physician, specializing in hyperbaric oxygen therapy, but also other kinds of things with the companies that we create. And so the Smarter Not Harder podcast, which is what you're a guest on today, so thank you for coming, has really been the brainchild of our nonprofit organization and our transcriptions company at the same time, to bring people together to talk about some really interesting ideas in the clinical world and the scientific world, biochemistry. And so what I wanted to start off with you, Dave, because your specialty is in is in neuroscience, is in psychedelics, is, what I find really interesting now is that, back in the 70s and 60s, we were using psychedelics to tune out, right? To drop out. But now we're using them kind of to drop in various ways. And so I would love to hear your thoughts about psychedelics and neuroplasticity. So I'm going to leave that as a open topic, and we can kind of go anywhere you want from there.
Sure. Yeah, that's a topic I am very much interested in. I think there's a common misconception about psychedelics in a lot of ways, and also about neuroplasticity. So neuroplasticity is something that means in a lot of ways, like the creation of new neural pathways, of new neurons, of new networks. And what that really means in very simple terms is learning, right? So it's not something that ever stops. We are always learning. Unless we stop ourselves from learning, then we will always be learning new things. That's what every moment of life is about, right? So if we think about neuroplasticity as learning, then when we think about what a psychedelic state does and what psychedelic means, you go back to the root word of psychedelics. Psyche means mind. Delos means to show or to reveal. So what we're doing is we're taking a medicine or entering into a mind state without medicine, like a dream or a meditative or mindful state of awareness, where we become aware of parts of our minds that were not in our awareness before, because our minds are potentially infinite things. Our minds are not only our mind and body, they're also constantly taking in information from the external world. And so our minds are in a lot of ways encompassing of all of that which is external to us, as well as all of that that's internal to us at the same time. And so when we enter into a psychedelic state, a state that reveals our minds to us, what we're actually doing is we're shifting. It's like tuning a radio, right? You're like shifting the filter in our brains that is allowing us to tune into stuff inside and outside that we were not necessarily aware of before. And much of that is what Freud called the subconscious, right? And Carl Jung called the subconscious. So this is this tuning, whether medicine's involved or not. And most of us have experienced psychedelic. I would say every single human being has experienced a psychedelic state in a dream before they've experienced it with a drug. And that tuning, which can be learned in dreams as well, with some mindfulness practices, and ancient yogis and meditators have done this for thousands of years, which many of them call dream yoga or sleep yoga, is very interesting. And it's something that allows us to expand our awareness and therefore expand our neuroplasticity or our ability to learn by increasing what we are able to allow into our consciousness. Does that make sense?
Oh, yeah, absolutely. The idea that neuroplasticity is simply learning is a fantastic sort of overarching idea for what I feel like neuroplasticity really, really means for people. I mean, you can talk about it when you have people that have certain types of illnesses or diseases where they have a particular condition where they're kind of stuck in a particular pattern of neurologic firing, if you want to call it that, and you can repattern that. And that's also called neuroplasticity as well. So when it comes to, certain psychedelics out there and how they really are able to do this, I mean, we have a lot more information now about, for example, ketamine or MDMA and how these things can repattern neuroplasticity. What is your thought at this point now with, as far as, ketamine over the last several years has been really intriguing to me. And obviously I know this is a big part of your clinical practice. How do you see this working in that way, in like a neuroplastic sort of way? And also the other piece of this that I find interesting and I think also involved is something we call epigenetics, the idea of how we can shift the expression of various genes depending on how we are, the environment internally and externally is shifting around us with the stimuli that we're getting, internally and externally. So I think it'd be great to focus on ketamine a little bit, because I know you do a lot of that work. And I know you mentioned before we started that you have some summits that are coming up that are using this in a particular way. So I'd love to hear more about how you kind of think about it in that framework.
Sure. Yeah, it's a very interesting topic because ketamine is the only legal psychedelic medicine that we currently have access to as clinicians. In the entire world, basically. It's legal in every state. It's legal in almost every country. I just had the privilege of presenting on this at the G20 Neuroscience 20 in Bali, Indonesia.
That's right.
To educate the developing world about, the benefits of ketamine assisted therapy, because it's not really practiced there and nobody really knows about it. despite its tremendous benefits for helping, as you kind of said, repatterning thought and thinking patterns around depressed mind or depressed states and getting people out of that state.
So thinking, how did that go?
Oh, it was great. It was great. It was so well received. I was so encouraged. I was really kind of concerned when I got there because I was like not sure how people would respond to it. But I realized that the developing world is interesting and that many of the folks who are there representing these countries from the health ministries, et cetera, are all just very problem solution focused, right? They're not like, oh, this is a religious issue or this is a tradition issue. They're like, help us solve our problems. We have millions of people who are depressed, millions of people with trauma and unresolved PTSD, and millions of people who have substance use disorders that are like literally, destroying themselves and their families. Let's solve that problem because then that makes our society better and happens to save a lot of money on healthcare expenditure. And they all have universal healthcare systems for the most part. So they're all like,
true.
So for them, I think, and this is something that's interesting, right, in terms of, we don't have to get into the policy, but when you think about the incentives that drive a universal healthcare system towards healing their population at the core, especially with mental health versus a privatized healthcare system, there's just completely different incentives whereby preventative care becomes the top priority, right?
Absolutely.
And preventative care includes mental health care and substance use. And that's also breaking a thought pattern, right? It's disrupting an old thought pattern, which is a neuroplastic event, if you want to think about it that way.
I love that, like the sort of like the global neuroplasticity right there. It's interesting because the way in is that you have this legal psychedelic, right? You have this legal psychedelic that is called ketamine, and that it's been used for decades, and we know the safety and we know how it works. And
as an anesthetic, as a pain relieving agent.
Yes, exactly. Yes, we know that. And we know how well it works in kids. It doesn't cause respiratory depression. I think maybe it would be good to kind of dive in a little bit on the mechanisms of ketamine, if you don't mind. I know you have a really good sense of this. And then I guess knowing the mechanisms, how that works with neuroplasticity and epigenetics would be really interesting topics to throw in there too.
Yeah, I mean, I think that's a great place to start. So I think that there's two ways to break it down in terms of the mechanisms of ketamine, right? So there's maybe three even. So the first, let's focus on two. So the first one is what we call the psychological approach, which is what happens in our sense of self, right? What happens in our perception, and then the second level that's interesting to think about is what happens on the neurochemical side, right? Mm-hmm. We'll start with the neurochemical. So on the neurochemical side, we don't necessarily understand how these parts connect to each other. We don't necessarily understand how and this is why ketamine is such an interesting molecule, is because we don't necessarily understand how the neurochemical relates to the neuropsychological. That still has yet to be discovered. And we don't understand how that connects to the epigenetic, which is the layer on top of our DNA that tells our stress response genes how to go up, to be turned up or down, or tells our skin cells that even though our skin and our brain have exactly the same DNA, the epigenetic layer says, hey, skin, turn down brain and turn up skin, right, and be skin. And then, hey, brain, turn up brain and turn down skin, right? We don't yet know how psychedelic medicines impact that, although there's a lot of theories around how that works.
Cool. Okay.
So ultimately, on the neurochemical side, ketamine is somewhat mysterious because we know that it impacts the NMDA receptor system, which is a glutamate receptor system that's involved in wakefulness and attention and that kind of thing. We know excitatory synaptic processing, the building connections between new neurons, likely, which is very important for learning and neuroactivity. We know that it impacts the opioid receptor system because as an anesthetic, it has potent abilities to impact pain responses. And that's how it was originally used predominantly. And a really interesting study came out of Stanford, maybe it was 10 years ago now or a little bit less, that showed that if you introduce into the body a opioid receptor blocker like naloxone, that you actually block all of the effects of ketamine. And so all of the effects. And that was really interesting because everyone thought that ketamine was primarily acting on the NMDA receptor system. Sure. Then they introduced this study which shows that the opioid receptor might be at the top of the chain. And then there's been other studies that have come out since then that have kind of pushed back on that because there's so much other stuff that ketamine activates to the point where it's what people would call a dirty drug. It doesn't have like a single target, which isn't bad. No, it just means that it's hard to figure out how it's working. So what's more interesting, though, once we know that it's working on multiple pathways in the brain and that there's certain receptors like NMDA and opioid receptors that are very important, maybe not essential, maybe essential, but very important, then the next step is to look at, and how that relates to the neuropsychological effects, right? Mm-hmm. And then again, this is still in study, but I think that what's really fascinating about ketamine and how it works neuropsychologically is that it is a dissociative anesthetic. So it's not anesthetic it's not pain relieving in the way that opioid drugs are, like oxycodone or morphine, where it numbs you to pain. What it does is it creates a psychological switch that flips, that dissociates your sense of self from the feeling of pain, emotional and physical, like creating space between. Right. And so this is really interesting from the mental health context, because what we see in psychiatry and depression and PTSD is that part of the pathology that people experience on the psychological level, what's happening in the mind, body, and sort of the distorted sense of identity, is that as we experience traumatic events, as we lack adequate support in our lives to understand how to cope with those events, or if that lack of support is so poor that we actually learn to blame ourselves or get blamed from the environment for the things that happen to us, we start to have this maladaptive response to trauma, where we actually associate the unpleasant feelings we have, like sadness or depression or trauma or stress, with our identity, to the point where we believe that there's something wrong with us as human beings.
Sure. Yeah.
Right. And so what happens is, and we've seen this in brain imaging of people who have these disorders, where you look at the connections between the amygdala and the fear center and the emotional brain and the prefrontal cortex and the frontal cortex, which are responsible for identity and decision making. And these are increased in connectivity in a lot of these folks, which suggests a correlation that we see in the clinic, which is that people are overly identifying a learned response that there's something wrong with me. Right? There's something wrong with me. And therefore, this experience that I had, which has all these feelings and emotions associated with it that are really just a learning opportunity, means something about who I am as a person, that perpetuates over time.
Right. And then it becomes its own self-perpetuating cycle, right? Because
it's attached. It's attached to our identity.
Yeah, to our identity.
But it's not actually.
Indeed. Yeah.
Right. So it's not actually attached to our identity. That's a learned association. Right. And so this is actually, in a lot of respects, since you wanted to get down to it, like, this is the fundamental dysfunction of mental illness at the core, is this malformed or maladapted association between identity, who I am, and what I feel and what I've experienced. And so the reason why ketamine is such an interesting medicine in the psychological context is because it doesn't just dissociate us from physical pain. It dissociates us from emotional pain, which W.H.O and a number of other folks showed at some really fascinating studies 10, 15 years ago, are actually relatively indistinguishable in the brain via neuroimaging. Emotional and physical pain kind of look the same.
Right. PTSD and TBIs, for example, can look very similar too, right? So,
right.
Right, we know this. Yeah.
And so if you can dissociate someone from emotional pain, meaning you can separate for even an hour and a half the duration of a ketamine experience, you can disconnect how I see myself from how I feel and the experiences I've had in my memory. All of a sudden, you have an hour and a half where you can look at yourself as an observer, an independent observer, without the pain, without the experience right there in the forefront, and without those two associated, you can look at yourself as an observer, and you can see independently, for maybe the first time in ever or a very long time, you can see, this is who I am without the attachment or the association of these painful experiences. These painful experiences do not define me. They do not define me. They describe something that I went through in the past. And that's a learning experience that is very important to remember, and it's very important to learn from so that we don't repeat it, but it's not the definition of myself.
Yeah,
right?
I think that's beautifully said. Yeah, I think a couple things come to mind. One thing, just to backtrack a little bit on the opioid receptors with ketamine, is it a dose-dependent change in the sense, does it tend to be more dose-dependent, meaning it will hit the NMDA receptors at a lower dose and the opioid receptors at a higher dose, or they really haven't been able to kind of piece that out at this point yet?
It's a good question. I believe it is dose dependent, but I would have to go, but I don't think it's differential in that, obviously in general with these kinds of medicines, one receptors usually hit more strongly than another.
Sure.
I think NMDAs hit more strongly than the opioid. I think it's actually a relatively weak opioid receptor modulator, but it's strong enough that it's having an impact on the outcome when you block it. Right.
Yeah, the dissociative piece goes away, right?
Right.
And that's because we know we use ketamine, obviously, for anesthesia, as we were describing before, at much higher doses than we would typically use ketamine for psychedelic-assisted psychotherapy, for example. And I want to get into that in a minute as well, because I'm really interested in the actual ketamine process itself, the actual experience, but also even more interested, actually, because of what I've seen in the post-ketamine period, which I think is really this amazing time frame where people have these huge shifts, and a lot of that has happened because of the work that you're doing, obviously, in the session as well. But before we get there, one of the things you talked about with the maladaptive patterns and these thought loops that people get that they identify as being part of, quote unquote them, although there is no self and all that is an illusion. And you were talking about planes before. It reminded me of Ram Dass's idea of like switching channels, right? He always talked about going from channel 1, 2, 3, 4, 5, 6 and things like that. So that was a super cool reference. But when it comes to maladaptive patterns, we do know some people are more susceptible to these kinds of things than others, in the sense that they have maybe family history, or they have other sort of underlying issues. They can have infections, they could have vitamin and mineral deficiencies. Like when you're thinking about somebody, and this is kind of like my clinical hat, I can't help it going on here, is that when I have somebody coming in to your office or to your clinic that comes in with these maladaptive patterns, these thought loops that you're thinking, okay, maybe they'll be like a great candidate for ketamine-assisted psychotherapy. Is there another piece of the puzzle sometimes where you're looking at their biochemistry, like and as I know, integrative psychiatry has really started coming aligned with the idea of like understanding some of this. I just wondered what your perspective was on this before we get to the ketamine piece a little bit more in depth.
For sure. Yeah, absolutely. And I should say also that, so this is actually a good segue into back to the neuroplasticity and the learning, right? Is that for our bodies to be optimized for neuroplastic learning, right? To be able to learn, our bodies have to be in a relatively calm, safe state, mentally and physically, right? We can't be under threat. Being under threat, whether that's perceived as anything from a predator outside our cave, or too many emails, or not enough nutrition, or too many responsibilities, or too much news, or any of these things will create a state of what we might want to call neurorigidity, right?
Nobody likes being rigid. Yeah.
Right. Well, most people don't. I mean, maybe there's certain times for it that are appropriate,
Indeed.
right?
Yes.
Like, especially like when you're running from a lion, you want neurorigidity because you don't want to be thinking about, oh, wow, I've never seen this part of the forest before, right? You want to be getting the F out of there, right? Sure. It's just very, very clear in those moments what the body has evolved to do to get us to survival, right? But the thing is that having that all the time, being in that state all the time, is not conducive to learning, because our bodies divert resources away from the learning parts of our brains to the survival parts of our brains and bodies. And so if we are constantly perceiving ourselves to be in a threatened state, for instance, by thinking about how something very hard happened to me, I wasn't supported when that happened, and therefore I now think about myself as not worthy of love, because there was nobody to help me afterwards, right? And I'm to blame for what happened. And then we start thinking about that over and over and over again. Then we get really good at strengthening the neural pathways around that, right? And what happens then is that we create a neurorigid state rather than a neuroplastic state. And we're literally impairing our learning in that way. So if you think about, going back to what you were talking about, that whether we are in a more neurorigid state on a day-to-day basis, or a more neuroplastic state on a day-to-day basis, that's more prone to negative intrusive thinking versus or positive learning thinking, has a lot to do with the state our physical bodies are in. How much sleep we've had is probably the number one most important physical thing, that's a physical mental thing that gets our bodies into a state that's primed for learning and recovered. Nutrition is number 2, movement is number 3, right? These things are absolutely essential. So in our practice, we do a full lifestyle medicine approach, integrative psychiatry approach that's holistic, right? We look at the whole body before we even make a decision about any kind of mental health intervention we're going to do. We figure out what's going in, what nutrition are you putting in, how often is it that you're putting it in, what are the supplements you're using, what are the medicines you're taking, how much do you move, right? What kinds of meditation or mindfulness practice are you doing, if any? We don't necessarily do a lot of lab work, except for looking at the core things that could go wrong in people that are very common. Thyroid dysfunction is a huge one, right? Whenever we have a new patient come in, if they haven't had a thyroid test, we always check that because it's a really common thing that can disrupt somebody's functioning. If somebody has chronic fatigue, you do a blood test because you want to see if they have iron deficiency anemia, very common, right? That's a dietary thing that is not unusual. And if you can treat somebody's depression by giving them a little bit more red meat or a little iron supplement every now and then without putting them on a antidepressant medication, that's a huge win because that's something that they can be in control of, and that it gives them a better understanding of how to manage their own health more effectively that is not dependent on us. Right. So optimizing the function of the body in advance, we always try to do as best we can before we actually move into the mental health treatment realm. But there's always a lot of education around that and a lot of communication around that, because it's all of this is, no matter what you're doing, like, right, it's always based on a trusting relationship with the provider.
I love that. On. I'm sorry to interrupt. I was just thinking, I love that framework that you use, right? Because I think that if you start off with the sympathetic, parasympathetic is really what you're talking about, the autonomic nervous system balance, and then focusing on that plus the nutrigenomics aspect of things, and then taking it down to the mental health side once you've addressed, or at least started to address, those kinds of things. And in my practice, it's very similar. You really want to get their foundation in order first by optimizing vitamins, minerals, nutrients, hormones, neurotransmitters as best you can. But at the same time, none of that's going to get fixed, in my opinion, if you don't also look at that autonomic balance, because this is something that's interesting. And I'm sure you've seen this before, maybe before you did ketamine psychedelic therapy, assisted psychedelic therapy, is that like you could do everything right with this person. You could give them the right therapy, whether that's, psychiatry, that's psychotherapy, or give them the treatment that's going to work for them, but it doesn't. And you have to, and you realize it's because you never worked on that balance with this person. They could never fully get into that neuroplastic piece, or that ability to actually heal and become parasympathetic. So,
or it works in the office, but doesn't stick thereafter. Right.
That's a really good point. So what is your experience like? Was that like a very prominent thing that you noticed when you first got into practice, when you started doing this?
Absolutely. Yeah. I mean, because I think most psychiatrists are not taught to do lifestyle medicine work.
No, they're not.
Right.
No. Yeah.
So I think, seeing that a lot of our practice was very heavily prescription focused, really led, and that a lot of our patients were still struggling with symptoms, like over 50% were still struggling with symptoms that were not going away. I started to work with a lot of lifestyle medicine folks. One of my colleagues, Michelle Thompson-Olson, is a lifestyle medicine leader at University of Pittsburgh Medical Center.
Oh, nice. Okay.
And she's basically pioneering the residency training program for lifestyle medicine for the first time for doctors
within psychiatry
across fields.
Yeah. I think doctors like you and I get like 1 hour of nutrition training in medical school or something like that.
Yeah, or like 5, but that's still not enough.
Yeah, I mean, whatever it is, it's ridiculous. I mean, that's amazing. I mean, I feel like this is a big thing across all medical specialties, but I think especially, it's hard to say just especially for psychiatry, but I mean, at least conventional psychiatry.
Primary care is absolutely critical, because when you look at primary care, and I think a lot of people don't understand this when they're looking at it from the outside, and I don't think a lot of trainees who are going into these specialties realize it from the inside, that 50% or so of people who come into your family medicine doc are reporting symptoms of mental illness, right? 50%. That means
it's probably more.
It's probably more. It's at least 50%.
Yeah.
And when you
I have
look
experience with this. So.
Right. Yeah, you know very well, right? And when you look at, in a lot of places, I don't even think psychiatry is a required rotation for the ACGME, like the American College of
No,
General
I didn't have to do a psychiatry. I did when I was doing my residency.
You didn't have to,
medicine,
right?
No, I didn't have to round. And when you're in medical school, you have to go through and do all these rounding and OBGYN and surgery, but you don't have to do psychiatry. That's not a required one.
Oh, that's interesting. I didn't know. Yeah, we all had to do it in medical school, but we didn't have to do it in, my colleagues didn't have to do it in residency.
I'm trying to remember.
I know it's an option. It's definitely an option for residents in family medicine to do it, but I don't think it's a requirement, which is really surprising when you realize that most antidepressant medications and most first touches with a patient with mental illness is through their family medicine or general medicine doc, right?
Yeah.
And then they're not getting the therapy. They're not getting the expert who says, oh, well, you're struggling with this. Let's go down the protocol of A, B, C, D. You're getting somebody who has never actually worked with these patients in an expert setting in the wild and had that mentorship and that know-how of, okay, let's not just check off the boxes and say, okay, you have depression. Here's your SSRI prescription. Try that. They say, okay, let me get you to the people who actually know how to solve this problem. Right? Because unfortunately, it's no fault of the doctors at all. It's just that the system is set up to get people in and out of the office as quickly as possible.
15 minutes. Yeah.
Yeah.
When I first graduated my residency, I did 1 year of primary care in Baltimore and an area called Canton. And
that's tough.
It was kind of a working class area. It was the people were very nice. Don't get me wrong, but it was, if I look back at it now, about 70% of what I saw was anxiety and depression. And the doc that I work with, he was a really great guy, and he did his best, but everything he would label as fatigue so that he could prescribe antidepressants. And so that's not because that's the only thing he could do for these people as far as he could see, right? And he only had 15 minutes to do it. So if they had depression-like symptoms, it was coded as fatigue and they were given antidepressants. So, and it's a big problem. And a lot of the problems have to do with just how the system is set up and how much time you have. But then the resources for doctors and practitioners is, especially then, that was like 10 years ago, was pretty poor. But now, I mean, over the last, 5 or 10 years, you have this huge swell of more information. There's integrative psychiatry, which is just an amazing field to me, and like the work that you're doing. And so I think if we have more resources for these people now, the challenge is that it's not covered by our conventional care kinds of insurance. And I know that you have to work outside that insurance realm, and I do as well, to do the work that we really feel like we need to do. I know that it's interesting. You were at the W.H.O. and talking to some of these countries that have socialized healthcare systems. There's just different intentions, or there's different motivations with these bigger healthcare systems. Although they're still misguided in a lot of ways, but they still have the potential to do these kinds of things in an interesting way. So, all that being said, I think you're right. I think the primary care doctors are like the first line of defense. And I know that this is jumping ahead a little bit, but I know that you're kind of working on ways to help train other doctors and practitioners on the work that you're doing. Is that mostly in the ketamine-assisted psychotherapy piece, or are you working on the integrative psychiatry piece as well?
I mean, it's all tied together, right? So I think going back to what you were saying before, we need, getting 5 hours of nutrition education in medical school when primary care docs are the first line of defense against mental and physical illness is totally unacceptable. Right? This is just not acceptable. It's not something that we as the primary providers can say is doing no harm to our patients. The education system is in fact doing harm when we tell our young clinicians that the first thing they should do for somebody is write them a prescription without doing a full workup, right? That is not okay. Again, it's not the fault of the doctors. I think this is a common misconception. The doctors are just trying to help. The doctors have put in more work than anybody else on the face of the earth to train to heal people. The training is not necessarily caught up with the times.
Right.
And so it's up to us, which unfortunately hasn't been a priority because we've been working so hard, and that it's actually up to us to work together like you and I do to revise and update the education, right? And that's everything from doing these kinds of interviews to actually creating curricula and protocols to go back to the med schools, to go back to practicing licensed physicians and say, hey guys, and nurses, by the way, and psychologists and everybody, and say, hey, we know that you might not have learned this in medical school or graduate school or nursing school. That's totally okay. It's not your fault. We didn't either. Here is what the latest evidence says about Lifestyle optimization. What movement does for mood symptoms, right? We know from a recent umbrella study, that huge study in 100,000 plus people that came out of University College of London, that showed that exercise is equal or even more impactful to managing symptoms of depression than SSRIs. If we all know that that's the case, and the evidence is saying that, why would we ever prescribe a medicine that could prevent you potentially from having an orgasm if you could just work out 30 minutes a day, right? Whether that's inside or outside doesn't even matter, right? If you work out 15 to 30 minutes a day and get your heart rate up, you'll have a better shot at sleeping better, which means your shot at actually addressing your core problems you're struggling with on the anxiety, depression level will have that much more of a chance of receding, of going away and being managed. And then you'll feel at the center of you'll feel agency, right? You'll feel as an individual who's seeking relief at the center of your healing experience rather than relying on a drug outside, which is what Hippocrates always said we were supposed to do anyway, right? So ultimately, because of this discrepancy between the way we're taught in school and the way that we actually practice medicine to heal people, I co-founded an organization, a nonprofit called the Board of Medicine, which helps to try to reset and realign our field around some of these core topics and re-education opportunities that are very much evidence-based in the field, but the trainings that we go through just have not caught up because the trainings are kind of rigid and fixed in the way that they've always been and not the way that things actually are now. So it's just, we're a board of world-renowned medical experts across all fields, including Eastern medicine and meditation and mindfulness, as well as nutrition, as well as everything from surgery to psychiatry, which who it's just, for me is interesting because I don't, as psychiatrists, we don't work with surgeons very much. No. Right.
The delirious patients post-op or something.
Right, exactly. But this is a very collaborative group that has all recognized these same issues that you and I are talking about, and to the point where we all work together to reevaluate the way we use medicine, the way we teach medicine as in actual drugs, the way we teach about lifestyle medicine, the way that natural tools like everything from mindfulness to exercise to plant medicines that can be used safely can help us to optimize the physical functioning of the body and the mind physically first. Because if we can optimize all of that physically first, then all of the mental, cognitive, psychological stuff is, we were talking about earlier, it's just that much more likely to stick. And then our bodies and minds are primed for learning or primed for neuroplasticity, right? Neuroplasticity and learning, in another way to think about it, is adaptation, right? These are our best skills as human beings. If we optimize our bodies and our minds together as one system, which they're not separate, as is a common misconception. If we optimize those together,
common misconception,
right? Then we're still like, this is what I'm saying. Like the field is still stuck in this Cartesian dualist viewpoint that is from what, the 1800s, 1700s, maybe older, where philosophically speaking, a guy who wasn't even a doctor said the mind and the body are separate because he locked himself in a room naked at candlelight for how many ever hours and decided to write the mind and the body are separate because he was tortured by his own thoughts. And all of a sudden the entire field up until this day still believes the mind and the body are separate. It's like, come on, guys. Come on.
Who does this, by the way, for everybody else here?
This is Descartes.
Yes. Yeah,
right?
Yeah.
And it's just like, how is it possible that we are still, as a field of doctors and world-renowned experts with the most training, way more training than Descartes had, still stuck in this dualist minds, dualist state of being where we perceive the mind and the body to be separate when they're clearly interconnected. When the body is physically sick and it's unaddressed, our minds become sick. When our minds are sick and it's unaddressed, our bodies become sick. They are not separate.
Right.
So we're trying to help basically dispel from the experts who actually know in an evidence-based way, here's all the science that shows all of this stuff we were talking about, forgive my language, is total bullshit and out of date. Here's what the current evidence shows, and we'll teach you how to do it.
I mean, it's just such a far way that we got into at that time frame from the ideas of our ancestors, right? And being connected to the land and connecting to the water and to the sun and yoked to the light and understanding that everything was connected. We didn't have all these fancy tools that gave us all the answers. We had to be intuitive about these things and feel where our body felt various kinds of things and feel where our mind was taking us. And also understanding that thoughts were just an illusion was a very big piece of a lot of the early Eastern meditation traditions, and how that really got taken over by the Enlightenment period. And then after that, that thought was king, and that was all that was necessary. And that's what happened with doctors as well. And then that's how you and I trained, is that, everything is just data, figure out a medical plan, done, right? There's no looking at anything underneath the hood. It's no understanding now there's a little bit more of this, but like even when I trained 10 or 15 years ago, there really was none of this stuff. There was no integrative department at my medical school. I'm sure there wasn't one at Penn either, right? Or in Pittsburgh, right?
No, it's just starting now.
Yeah. So there's an integrative department now at University of Maryland where I trained. And it sounds like your colleague, the lifestyle medicine practitioner, is part of that big piece at University of Pittsburgh, right? So, it's really gotten to a place now that organizations like this are now, it's like the perfect timing, because people are actually ready for it, especially with the psychedelics coming on board and more people interested. The training programs that you guys are going to be doing, are they programs for all kind of comers? Are they for doctors, for practitioners, or who's your focus right now?
So right now, a big piece that is missing in the psychedelic medicine space, well, so it's for everyone, in short. I think that what our field needs more than anything, especially in primary care, going back to who's on the front lines,
sure,
is that our frontline folks need to understand how to talk to our patients better, or prospective patients, about what tools they have available that don't require a lot of money or a lot of reliance on the healthcare system, that kind of like really empower them to make positive change in their own lives. So that's for everyone, but primarily for primary care physicians. Okay. The trainings that are offered currently, we partner with psychedelic.support to offer trainings for psilocybin, ketamine, and MDMA assisted therapy. Obviously, the only one of those that's legal right now is ketamine, but they all work in generally the same way, with different amounts of time duration that the drugs are active for.
Sure. Ketamine being the easiest there.
Ketamine being the easiest, the most readily available right now. We deliver it via telemedicine at home or in person. It can do both. It's the most flexible by far. And a lot of
favorite delivery device. Yes.
Yeah. Using oral or sublingual troches, which are, oral dissolvable formulations, which are really powerful and effective. And so, I think the point is that these are guidelines for all practicing clinicians on the front lines of particularly primary care. So that includes everyone who's family medicine, internal medicine, OBGYN, psychiatry, nursing, psychologists, social workers, people who are going to be educating patients about what options they have. Because if we don't know what options they have, and we are still like, oh, well, cannabinoids are not good, all bad, not going to talk about them, but 50% of our patients who have pain come in asking about cannabinoids as an alternative to opioids, then we are going to be misleading our patients, rather than saying, hey, by the way, if you are interested in coming off of your opioids, or you're interested in using something else other than opioid narcotics, which have very, very significant risk, 1 in 550 people die from using opioid narcotics, by the way, for pain. Like, this is a serious thing. And don't need to, go into detail on that, but this is a serious thing. Nobody dies from cannabinoids toxicity. Nobody. So you look at what the options are and you say, okay, well, maybe THC isn't the answer, but maybe the evidence says it's a high CBD, low THC, like 20 to 30 to 1 combination. Here's some of the evidence supports that. Try it. Here are some brands that are reliable that you can use, that you can buy wherever you are in your state. Or here's a CBD formulation that is organic, non-GMO, whatever, that is has some evidence for being helpful with pain or with inflammation, and it has 0 side effects for the most part. You can try that. You can order it in any state. All of a sudden, you've given that person an opportunity to try something new that doesn't require a prescription, that doesn't have the risk of respiratory depression and death, right? That they're not relying on a physician for. That is a serious empowerment moment for our clients.
Yeah.
Right.
So let's talk about that, because I think one of the things that I really love about the work that you're doing overall is on the empowerment side of things, getting people their own ability to take care of themselves, their own health. And you mentioned depression earlier, and definitely a lot of great work that's been done in the last recent years showing that antidepressants are not the answer for most people. There obviously is a certain subset of people that do need these drugs, and that's totally fine, even if we don't know exactly how SSRIs are working. And that's some interesting work that we could talk about later if we have time, as far as those new studies on SSRIs and whether they do anything for depression directly is an interesting question. But we do know they do help people in like with major depressive disorder. If there's definitely a role for them. But when it comes down to empowering patients, what are the main ways that you typically will do that in a clinical setting? I know that you probably have things you do before, during, and after your mental health journey with these people. But I would imagine a lot of these have to do with the balancing of the autonomic nervous system, especially.
Yeah, absolutely. I mean, I think that there's a couple things that are really at the core that are again mostly like psychological or thought based. So the first is that when you have a physical or mental illness diagnosis, or you've had a very intense series of stressful events that are perceived by you as trauma, or you're not supported afterwards, and they change your sense of self, that change of sense of self puts us into a state of being where we kind of identify as victims of the situation, right? Victims of life. And that creates a stress response in the body. That creates a sense of fear of self. It's not okay to be me, or it's only okay to be me if I'm a victim, right? And so one of the things that's really critical to understand about that process, whether it looks like depression or whether it looks like PTSD or whether it looks like insomnia or physical illness, because it can look like any of those things, or ADHD or what have you, it can look like any of those things, is that it is based on a state of, in a lot of ways, self-denial, self-fear, right? And starting to perceive ourselves as a threat to our own selves, or not feeling safe in our own skin. And that's setting our sympathetic fight or flight response up just by being alone or trying to fall asleep at night by ourselves, and decreases activity to our parasympathetic system. And ultimately that the most common single thread that ties all that together is that if you're in that state all the time, and you've had these experiences that you perceive yourself to have gotten yourself into and to be to blame for, what happens? You don't trust yourself, right? You're afraid to be by yourself because I can't trust myself, take care of myself. I can't trust myself to make sure that I'm going to keep myself safe. That's the core issue that we are dealing with in all patient encounters, physical and mental illness. That's at the core. And that's not generally something that's going to be just like on the surface calling out to you. It's going to be something that's buried deep down. And so what we do when we start work with folks is really built around the restoring and repairing the foundation of trust in the individual. There's a bunch of different ways to do that. There's Western techniques. There's, just having the simple thing is just having an empathic conversation with the individual, where you're sitting there like we are today, looking into each other's eyes, even if it's on Zoom, and having a clear line of communication that is non-judgmental, where that person knows when they're struggling that they can literally say anything they want to us, and we will not judge them for it. We will not make them feel badly. We will not make them feel like they're less than worthy because they are expressing vulnerability to us, right? That is and they're heard and they're seen, right? That is the single most important thing that we do for our patients, that literally any human being can do for any other human being without training. Right. So when we really think about, again, breaking it down to the simplest form of healing, this is something that we can all do for each other without training. It's just listening to each other without waiting to speak and without judging, right? Just letting somebody know that they're heard and seen. That is fundamentally critical. The reason that's critical for healing and what that does is it reminds that person what it feels like to trust, right? So then if you don't trust yourself, or you've learned to not trust yourself for any number of reasons, all of a sudden you're like, oh, this person hears and sees me and they're not judging me. I can trust this person. If I can trust this person, doctor or not, then I can remember what it feels like to trust. If I can remember what it feels like to trust, I can learn to trust myself again. That's when the more doctor stuff comes in, because that's when we're like, okay, well, now that we have a foundation of trust between us, let me give you some tools that can help you remember what it feels like to trust yourself, and then help you learn how to trust yourself again. And those tools are, number one, things you can do on your own to improve your quality of life. Movement, I call it like there's like 4 or 5 pillars, right? There's like movement, intentional breathing, right? These are all the things that we have control over in any moment. Movement, intentional breathing, soothing touch, soothing music, sleep, and if we want to call a 6, it's nutrition. The fuel that we put into our bodies. These are things, for the most part, that we have control over at any time, particularly the first 4: music, touch, which we can apply to ourselves, intentional breathing, and movement. Right? So those are the 4 core pillars, and then sleep and nutrition are absolutely critical that follow right thereafter. Right? So giving people those tools after you've built this foundation of trust and saying, hey, colleague, friend, person, I see you as an individual human being. I see that you have power, but you feel like you've lost it. Now that you're feeling safe in this environment together, let's give you the tools to give you that safety back when you leave. The problem is learned not safety is just as powerful, if not more powerful, than learned safety. So the brain is an automation machine. If we've learned to feel unsafe for very, very long periods of time, we've practiced learning that, we'll get really good at it. And so even when we have these incredible safety restoring experiences in the office, people will still leave and feel unsafe when they leave. And it'll be harder to learn these new things and practice these new things, because when we feel unsafe, even in our own skin, learning is deprioritized and impaired, right?
So cue the ketamine.
So cue ketamine, but also cue Apollo, right?
Sure.
So this is where and the tools that you guys work on, right? Trocom. The idea is, how can I give you a supplement or a stimulus boost or a soothing touch thing that activates your sense of self-control, self-autonomy, and your functioning of your body, and your sense of felt safety in any moment, right? So in the case of the supplements and ketamine, they're like Trocom, and they're neuroactivating molecularly parts of our brains that increase our ability to cognitively function, increase our brain functioning and our body functioning. They decrease inflammation, and molecularly they work in a way that we don't necessarily understand, but they work in a way that helps the body feel safe.
Right.
And then that helps us to function better. You're optimizing the fuel you're putting into your super high performance vehicle. Right. The Apollo works in a way like topically through the skin that delivers a tactile stimulus, a very gentle vibration that you barely notice, but you notice it enough that it reminds you, just like a deep breath, to feel safe. And then it reminds you to breathe. And then it brings your sympathetic, parasympathetic nervous system a little bit more back into balance, which then helps you think a little more clearly, helps you sleep better, and helps your body get into more of a recovery state more of the time, which then serves like these other tools as a training tool you can kind of take on the go. And whenever you need it, it's there for you to help get you back into that state. And so that's where you get that durability or stickiness that lasts over time, not just in the office, but also outside.
Yeah. I mean, and I know that the journey for Apollo with you was many years in the making. And if I'm not mistaken, you didn't even think about making this into an actual device until like the very end, right? It was just ways to try to help people through vibration and touch was really what your initial drive was. Is that right?
Yeah, absolutely. We had no intention to start a company, actually. And we were doing research at the University of Pittsburgh, working with these folks with treatment-resistant depression, treatment-resistant PTSD. Medications weren't working for them. And so I decided to ask the question, what's going on in the autonomic nervous system? Do these people have a disrupted stress response? Because in the office, they certainly look like it, right? And then what have other people seen? It turns out others had seen in the literature that almost everyone with depression and PTSD has a disrupted sympathetic autonomic tone, sympathetic and parasympathetic balance. And you can look at that by tracking HRV and resting heart rate and these other things. Wearables are also, in general, a really great tool for people to restore a sense of self-agency and self-autonomy.
And for tracking over time, absolutely.
And for tracking over time, but it has to be over time, not
with
in the
interventions
moment.
as well. Yeah, as you go through and see how things change. Absolutely. Yeah.
Right. And so we started to see those patterns that we noticed and that other people confirmed. And then we said, okay, well, if there's disruptions in these systems, what techniques reverse those disruptions? Well, intentional breathing, soothing touch, soothing music, meditation, mindfulness, yoga, movement, all these things I just talked about are all improving that balance. And that's why they work, but they also take time to learn. Indeed. There's a learning barrier. If the body is in a constant stress response, particularly if you have PTSD or particularly if you have depression, learning is harder. The body is in, and the mind is in a neuro-rigid state at the start.
The DMN is high
yeah,
acting, right? So
right, yeah. I mean, we have entrained these loops of thinking about ourselves as dysfunctional. So if you think of yourself as dysfunctional, why would learning be something that you're capable of, right? Mm-hmm. Why wouldn't you just do the same thing you've always been doing? That's what feels comfortable. That's what we know, even though it doesn't necessarily serve us or make our lives better. So we thought, okay, well, if we understand that touch is so powerful at boosting all these neurotransmitter systems in the body, endocannabinoid activity, endogenous opioid activity, endorphin activity, serotonin activity, dopamine, oxytocin, all of the good molecules that we take drugs to support. Indeed. And we can get it with touch. Why wouldn't we try that? And so we decided to just do a bunch of experimentation. We figured out before we had a wearable device that we could actually induce these states of heightened calm and mindfulness in the lab, and those correlated with improved performance physically and mentally, and improved HRV, even in just as little as 3 minutes in a protected space. And then we were like, okay, this is cool. Let's create a wearable version that Catherine, my wife and co-founder, and the business brains of our operation figured out how to raise some money from the university to make. And we made a whole bunch of prototypes. We gave them to 3,000 people in the real world, and they are actually getting the same results we were seeing in the lab. And at that point, we were like, okay,
you had something. Yeah.
We have something. Let's try to make this into a consumer product. And now it's available. And now, after you've tried this is the chest version.
I haven't seen it. I saw that at the conference in September, but I didn't get to try it. So.
Yeah, so now you can, we'll send you a clip. Okay. But it's just it's the same Apollo, but it's clipped on. And the cool part is that unlike other wearables, you can actually wear it anywhere in your body because it works by delivering touch to your body. So you don't need to wear it on your wrist or your ankle. You can actually wear it anywhere, which makes it a little bit more convenient for folks.
Yeah. I think you were strapping something on my ankle in 2019, and then you had the wrist and everything else. So, I mean, I think it's wonderful that we give people these opportunities to take advantage of their own biology and their own system. I mean, I think measuring what they need from a nutritional side is really important for a lot of these people too. But having the ability to give things on demand for people as they are going through, like the whole idea with our nonprofit organization, Dave, is like, we know that sustainable health requires foundational health focus. And that's looking at vitamins, minerals, and nutrients, and looking at the psychiatry or psychology piece of this is extremely important too. But you also, throughout that whole process, you have to give people things that they can do right now so that they can feel better right now, so they can continue the process of optimizing their health, of working with their mental health issues or whatever it might be. So I think the Apollo is a fantastic example. And, certainly what we have at our for-profit company, Transcriptions, the TroCom product, is something that also helps balance the autonomic nervous system as well in an on-demand sort of fashion. And I think people need all these different types of ways and opportunities, but the idea really is to integrate them into a type of framework that really works to help shift their physiologic function from the ground up. And then, as you were talking about, make it stick, not just have them come into the office, feel better. And I have a lot of history with this in the various things that I've done, that you get them better in the office, then all of a sudden they just kind of 3 months, 6 months, a year later, they go back to the way they were before. This is in people that, quote unquote, should have had full recoveries or whatever you want to call it. So when it comes to the ketamine side of things, and there's ketamine assisted psychotherapy, and there's also the integration piece post ketamine. And I would love to talk a little bit about sort of those pieces of the puzzle for you. I know you've done a lot of training here, that you train other doctors. What it's like the high level things that you think are important, like in session and then like immediately post session for most people?
That's a great question. So I think that, this stuff we've all been talking about is critical pre-session,
sure,
right? So it's building this foundation of trust, building with the client, and building and restoring this understanding that the power to heal comes from within us, right? It's not something that you're reliant on me for,
right?
Which is often another common misconception, that you have to seek your health from outside of you, right? Health always comes from inside of us. So This is absolutely essential to understand, and people don't always get it completely before we start, but having that concept in your mind is very, very helpful to understanding how the medicine works. Because the medicine is a teacher. The medicine is a teaching tool. It's a tool, and we are teachers as clinicians, right? We're teaching you how to heal yourself with the medicine, and how to use the medicine to activate healing states in your body so that you can then activate them yourself on your own, right? So if you think about the way that works, then that applies to literally all applications of medicine. It applies to everything from SSRIs to amphetamines to psychedelic medicine, right? To cannabinoids. You introduce an SSRI to somebody who has a selective serotonin reuptake inhibitor like Zoloft or Prozac, and you introduce that to somebody who has severe depression or anxiety, who doesn't remember what it feels like to have any sense of like evenness or calm. All of a sudden, that creates a little bit of numbness, you know, within several weeks on the bottom end, the low end of emotions that are the most disruptive, that prevent that person from getting out of bed and feeling functional. It also creates a little bit of numbness on the top end, right? But it creates enough of a stabilization on both sides that people are able to remember a little bit about what it feels like to have a normal sense of self and life again. It brings them back, and it gives them that sense of felt control if it's done properly. Obviously, the therapy is a critical component of that, because the medicine alone is not doing it. It's the combination of the relationship built with the doc or the clinician and the medicine that works together. And every single study of SSRIs shows that you put them together and it always works better than drug alone. This is no different than with amphetamines. It's no different than with ketamine. It's probably no different than with any other medicine.
Sure.
If you have therapy plus medicine, it always works better. With amphetamines, you give somebody an amphetamine and you say, hey, try this because you have trouble focusing for sustained periods of time on stuff that is not interesting to you, like video games. So let's give you amphetamine and let's see how that works. And all of a sudden they try it and they're like, oh my God, I can focus on my homework. All of a sudden there's a learned experience of saying, I now know, drug aside or not, I now know what it feels like to focus on something for an extended period of time. Now that I know what this feels like, you have the therapy to help you understand how to do that without the drug, right?
I love that. Okay.
So this is the same thing that we're doing with ketamine. We're saying, okay, you've been spending your whole, as long as you can remember, associating your sense of self with these very challenging experiences or traumatic experiences you've had, and associating those to an extent where it means something about who you are as a human being, that you're not worthy of love, you're not worthy of affection, you're not worthy of acceptance by your community, and there's something wrong with you because you had these things happen to you, right? Or you had these feelings all the time, so there's something wrong with you. I can tell you to the end of the road that that's not the case, but you're not going to believe me because that's what you know.
Right.
All of a sudden, I introduce ketamine or MDMA or psilocybin in the right environment, but for the sense of what we actually do in our practice, you introduce ketamine for an hour and a half. That tape that was playing in your brain that is basically recorded from long ago that says, this is how I see myself in the world. Ketamine neuromolecularly pauses that tape in the context of the safety of the therapeutic experience with me and my therapist colleague holding space for you. And all of a sudden you have an opportunity to see yourself for who you actually are without that tape playing. And the first thing that people say when that happens is, oh my God, there was a tape playing, right? Yeah. And then the second thing is, okay, well, now I have these trusted helpers with me to teach me how to revise that tape. And then we teach them how to revise the tape, and then they do it on their own.
This is the default mode network we're talking about here to some degree, right? The part of our brain that gives us the stories of who we are, what we're supposed to do, what we're good at, what we're bad at, all this, our stories. Do you see, is there some literature out there and some data about default mode networks specifically with ketamine therapy and how it's being dampened, or is it not really there yet as far as understanding?
Yeah, I think that in general, I mean, I haven't seen a ton of it with ketamine specifically, but I think what we see with meditative states and psychedelic states is...
Certainly with LSD, right?
With LSD and psilocybin, is that if the default mode network is the way that our brain, all the parts of our brains are talking to each other at rest, then, and it's associated in a directly linear way with our sense of self, ego, what Freud called ego, there is a dose-dependent relationship between the amount of psilocybin you take, for instance, as shown by Rabin Harris's group in Imperial College. There's a direct relationship, dose-dependent, with the amount of psilocybin you take and the amount of ego loss, the sense of loss of sense of self, and the amount of therapeutic outcome benefit, right? So those are all aligned.
Heroic dosing is what we're talking about.
So, no, it doesn't even have to. I mean, it's not necessarily heroic. Like it's dose dependent.
Sure.
Right. So even smaller doses create a little bit, and then bigger doses create more, and that the amount of ego, the amount of loss of sense of self, is directly correlated with the amount of symptom, or in this case, it's dose dependent. So as the dose of medicine goes up, ego, sense of self, default mode network activity goes down, and then clinical outcomes get better, and people feel generally better and have these more powerful, meaningful experiences. And so, but again, to your original question, it's critical to have therapy and what we call integration therapy afterwards, because that's what makes it sticky. Because you can have these tremendously meaningful experiences under the influence of the drug, in the clinic or in a lab or whatever. You can have these, or in a ceremony, you can have these incredible experiences, but there's a lot of stuff that comes up. There's a lot of material that bubbles up from our subconscious into our awareness conscious that we have to then do something with. And if you don't do stuff with it in a constructive way, it can actually become destructive, because that needs to be integrated into a whole sense of self. Integration is about bringing all the parts together afterwards, right? So if we become aware of all these parts, hurt parts, sad parts, vulnerable parts, and now we're like, oh, well, now I have to carry these around every day. Before it was better because I didn't even know about them. I was just dealing with it. Now I'm aware of them. Well, what do I do with that now? Right? Then that could actually be really difficult and challenging and make things harder. And so the integration therapy is that talking it out afterwards with an expert that follows, that we do a lot of in our practice, where we help you navigate how to put all the pieces back together into a whole sense of you.
Right. And I think that's where a lot of these newer programs out there, like especially in the ketamine side of things, fail miserably, where they give you an IV of ketamine and maybe sit with you during your experience, and then kind of you're out the door kind of thing. And because it feels to me that, at least from my own personal experiences with this, and also with some patients that I work with, it's that post-ketamine cleanness, like that, just like you feel like you're almost like resetting yourself to some degree, and having the ability to learn in that period is extremely, extremely possible, is what it comes down to. So like that integration piece is huge. And so like in your practice, you're doing a lot of that extra piece of taking that time frame when they're using the ketamine and then in the post-ketamine period, and really doing a lot of integration, which is awesome. I know we've been talking for a while, Dave. I don't want to keep you too long, but one thing I wanted to ask before we finish is that, you and I have had mutual patients where things have not gone well with psychedelic experiences. And I'm sure you've seen more and more of this over the times that you've been in practice. And I was wondering, for those that might be listening, or those clinicians that might have patients that come to their office and they just had an ayahuasca ceremony and they've not come down, or they're still anxious, or they're having maybe even suicidal ideation. I mean, I've seen people like this, and I'm sure you have too. We know that psychedelics are very safe overall. I mean, LSD can't kill anybody. DMT can't kill anybody directly, nor can, ketamine probably could at very, very high doses, but I think it can. Can it? I think it can. But anyway, I guess the question is, do you have a framework that you use when somebody comes in with a bad psychedelic experience to your practice, and how you would kind of, just sort of in broad strokes? I know there's a lot of details here, but how would you approach somebody like that?
Yeah, that's a great question. I mean, this is one of my favorite groups of folks to work with, because I feel like there aren't a lot of people out there that do this kind of work. There are very, very few resources of highly trained individuals, particularly psychiatrists, that can help manage these situations, because they're scary for a lot of doctors. Most doctors and in clinicians in general just don't understand how to navigate these parts of the subconscious. And, for us, it's really an exciting exploratory opportunity when everybody says, oh, well, nothing I can do about this. We say, well, let's give it a shot. Let's try to bring you back home. Right. And I think it's really all the same stuff we were just talking about, but in a much more intensive, frequent way, where everything is about just rapidly, as quickly as possible, making sure that patient feels in a safe, trusted environment, and that they can be safe with their own thoughts, and that they know their thoughts are not who they are. They're just thoughts, right? And that their emotions are not part of who they are. They're just signals, right? And that their experience is not part of who they are. They're just things that happen that we can learn from, right? And so reframing all of that and restoring that sense of safety is absolutely essential as quickly as possible when somebody's had these kinds of experiences, what we, describe in the medical community as like a drug-induced psychosis.
Yes.
Believe it or not, the times that we see this the most are when people accidentally or, don't realize what they're doing when they mix amphetamines and cannabis, THC.
Interesting. Okay.
THC and amphetamines, not a good mix. I know people who use them very occasionally and have used them for creativity and all these things and whatever, that's fine. But people use them daily, often, and that is not a good mix. And they actually, it's this combination that we've seen. I don't know how much this is written about in literature, but I can tell you from clinical practice that we see people mixing, when you mix a stimulant and a dissociative, you're like rocket shipping yourself out into the nether regions of your consciousness. And you don't necessarily, if you don't have the environment and the therapeutic environment to like make sure that you come back, every time you do that, you're like pushing yourself out a little further, right? Does that, the metaphor kind of, so if you think about it from that perspective, and that can happen with stimulants like based psychedelics as well.
Right. That's what I was thinking about as you were saying it. Yeah. Like
psilocybin, LSD, combining MDMA with cannabis, combining any of these with cannabis, like psilocybin and cannabis, specifically cannabis, I'm meaning THC, LSD with THC. Anybody who's ever done that knows that that is a rocket ship straight out into the distant realms, right? And so that is something that we need to be very careful of, is this mixing of substances that distorts our sense of reality in a way when we don't have the frame of safety to come back to, and we don't have the integration set up to understand how to put all the pieces back together. Right? It's not to say all these mixes or combinations are bad. It's just that if you're going to do it, make sure you're doing it safely and you're doing it in a way where you understand what you're doing it for a good reason, and you have planned intentionally to bring all this back together. And so ultimately, if you've already broken up and shattered your consciousness and you're coming to us because you've blasted yourself off too far and you don't know who you are anymore, then it's a lot harder and takes a lot more time for us to put the pieces back together. Right. Pretty much like kind of like the Humpty Dumpty metaphor, right? Like it's really, really hard to put things back together. It doesn't mean it's not possible. It's generally possible. It's just hard. It takes a lot of time. And this is a big focus of our practice. It's a big focus of some of the media that I create on Clubhouse. We have done a show. We took a break from it, but we're bringing it back, called the Bad Trip Doctor Show, which is basically helping doctors and clinicians and patients and people who just had bad trips understand what they mean, why we have them, and how to come back from them. And that they're not permanent. In general, they are not permanent. They're just very challenging experiences, almost like a self-inflicted trauma accidentally. Right. And so then how do we repair that and get somebody in a state to adapt to and cope with that and come back? And so it's everything we just talked about, built on the foundation of trust, plus a lot of this, a lot of Apollo, a lot of CBD, that's really high quality CBD, particularly acidic CBD. My favorite brand is Artist Botanicals, which makes one of the best CBDA products that I've ever worked with. Sometimes a little bit of like, other mood stabilizing agents that can be really helpful, just kind of surrounding people with the mood stabilizing agents that ground you back into your body and help you feel safe in your own skin again.
Yeah, obviously having tried to avoid the psychedelics, that's the other thing, right? So that's probably the one piece that's different in people that have had psychedelic induced psychosis, is that you don't want to potentially, although maybe there are times that you do it, but I'm sure that's like not the focus. But I love that.
Definitely not. Yeah. And no stimulants stimulants, no psychedelics and no stimulants and no THC, right?
Those are the main ones. Okay.
Yeah. You gotta eliminate all that stuff as the number one thing.
Do you ever think of it from like a neurotransmitter perspective? So if they've had like if they just went off the rails on DMT, for example, are you going to try to replete some of the neurotransmitters, or psilocybin, same thing, like getting them on some supplementation? Is that ever kind of in that purview too, or are you kind of mostly focused on other aspects?
Yeah, we do think about that, but I think it's from the standpoint of mood stabilization, right? Okay. And like optimizing the functioning of the body so that the person feels comfortable in their own body.
Gotcha.
Right? Yeah. So if people feel much more comfortable in their own skin, then it's easier to come back to your own skin.
Gotcha.
If your body feels like an unsafe place because it's not healthy and well, and it's not well nourished, and it's not exercised, and it's not used, and it's not comfortable, then people will want to go into the, escape land, which doesn't really exist. Like, there's no escape from life. That's a fallacy. Like, literally, there is no escape. So if you plan your whole life around, or your outcome as, oh, well, my choice is I don't feel comfortable here, so I'm going to go there.
Right.
You're always going to wake up and find yourself back here.
Right. Yeah, wherever you go, there you are, as they say, right?
Mm-hmm.
Well, that's beautiful. That's actually really helpful for me personally, just understanding a little bit more about your framework, because I do see more of these people coming through my channels these days that have had psychedelic-induced psychosis of various degrees. And I do appreciate your help with some of these patients that you've been kindly able to give over the last couple of years, Dave. But this has been really helpful for me to listen to some of your thoughts of how this is all working in the world of psychedelic-assisted psychotherapy and your framework, and obviously the Apollo and the parasympathetic and sympathetic balance. And I'm really excited where all this is going. I know that you and I will be, and our companies will be doing more collaborations. And I'm excited for you're going back on Clubhouse. I thought Clubhouse was dead, but no, you're keeping it alive. So you have a couple of things coming out you mentioned. I want to make sure we talk about those, and also just kind of where people can find more about you, and also obviously the Apollo too.
Yeah, absolutely. So thank you, by the way, for having me. This was really fun. I really enjoyed chatting with you as always. It's been way too long since we've done this. So
I know, we'll do more.
Yeah. So for anybody, first off, just closing on what we were just talking about, if anyone needs help, because I know it can seem hard to find help with these kinds of very challenging experiences where psychedelic-induced psychosis, drug-induced psychosis of any kind, it seems like there's nowhere to go. There's always somewhere to go. Reach out to one of us, please. You can find me and reach out to me directly through my clinic on my website, apollo.clinic. It's really easy, Apollo, APOLLO.clinic. And you can set up an appointment literally from our website. It's like, I don't know, $30, $50 for an intake just to get you seen and heard and get you into the work.
And that's locations in a couple different places, right?
Yeah. We're located in New York, Pennsylvania, and California, but we do most of our work remotely because it's easier to give access to care remotely. So it doesn't matter where you are, just reach out to us. Awesome. We're happy to help. If we can't help you, we'll find somebody that can.
That's awesome.
So we just want you to know, everybody to know who's listening, that there is help, and that we are happy to, as I know you are too, to connect people to get care wherever possible.
That's awesome. Then I would just send them to you, but that's perfect.
Sure. Happy to. Always happy to assist with that. And then if you're looking for Apollo, you can go to apolloneuro.com or wearablehugs.com, which cute. Will take you, because that's basically what it feels like. So wearablehugs.com, we have a great Black Friday sale going on right now. I don't know when this will be out, but
probably after that.
But yeah, go check it out. There'll
probably be really great deals whenever this podcast is released.
There will. Yeah, we'll make sure it happens. And on another note, we should make sure that you have an affiliate code for your group. To give your audience a special discount as well.
We'll have a show note in our show notes. We'll have a discount for people that are listening. Absolutely. Thank you.
Just reach out to me about that. And then we have my podcast, my first podcast that is focused on both live and very special interviews that I've been doing with leaders in the field of mental health and psychedelic therapy. And many of the pioneers who we've mentioned here will be called the Psychedelic Report. You can check it out at thepsychedelicreport.com. It's the first ever psychedelic news show. They'll be giving you weekly updates starting in about a week or two starting, I guess, the first in December of 2022, giving you all of the latest, most exciting things about psychedelic medicine and what's going on now and what is also to come. And if you're a clinician interested in training, please check out theboardofmedicine.org. This is a nonprofit we were mentioning earlier. There are trainings that are CME and CE accredited right now that you can go on our website and get discounted access to through the link right on our homepage. And we'll have many, many more to come around cannabinoid medicine and around other forms of psychotherapy. And we also do apprenticeships. So if there's anybody who wants literally to train with me or to train with one of my expert clinicians who are seasoned at doing this work, we are accepting clinicians to join us now, primarily psychologists and MDs who are already licensed. But there are almost no other apprenticeship programs nationwide. There's only maybe a couple, and they're all mostly filled. So we have a couple openings. So if you are listening and you are interested in doing this work and learning how to see patients the way we do, we're happy to teach you, and please reach out.
That's amazing, man. I'm so excited for all your endeavors and the work that you're doing in these fields and how it integrates so well with, obviously, personally, the work that I do, but also just, making the world a better place through all our channels and all the work. So thanks. Keep up the great work. And I look forward to chatting more, integrating more, having fun more, all those kinds of things too. So until next time, Dave.
Likewise. Take care. Thank you.
I hope you enjoyed this episode with Dr. Dave Rabin and yours truly, Dr. Scott Sherr. If you did, please like and subscribe below so you never miss another Smarter Not Harder podcast episode. This episode was also brought to you by Transcriptions, the makers of buccal troches that are precision dosed, pharmaceutical grade, and physician formulated, as well as Health Optimization Medicine and Practice, a nonprofit organization that's training doctors and practitioners on how to optimize health rather than treat disease.